Discover KDH Collective's Leaning into Therapy podcast, an enlightening exploration of therapeutic approaches and evidence-based protocols. Join us as we delve into the vast landscape of therapeutic interventions, guided by the belief that collective intelligence surpasses individual expertise. Led by Katie Holmes, a licensed professional counselor with 16 years in private practice. This series offers valuable insights, expertise, and training from a team of skilled therapists. Prepare to immerse yourself in the world of therapy, created exclusively for therapists by therapists. Welcome to another episode of KDH Collective's Leaning into Therapy. Today, Monet is going to interview me again.
I'm very excited about it. We are going to dive deep as one can, into ERP, which stands for
Exposure and Response Prevention.
I love it. So much easier to say ERP though, but you are the resident ERP expert in the context of our practice. So who better than you to answer these questions? So diving in immediately, we went through what does ERP stand for, but what are the foundational principles of ERP?
Well, and I want to start by just like a brief description of what is ERP. So ERP is exposure and response prevention, which means we expose ourselves to our fear while abstaining from our compulsive behavior. And I say our because I feel like I have my own history with this. It's made for OCD. For people with OCD is the gold standard treatment for it. And one of the main principles, I think there's two that I'm going to talk about. It's habituation. So by exposing yourself to your fear while abstaining from your compulsions, when you do that habitually, you might have less anxiety over time. So what was terrifying will soon be not as terrifying because your body can't hold the same level of distress when faced repetitively.
So like building tolerance to the distress of it all.
Well, so some people actually have less distress, and then some people have what they learned that the inhibitory learning model, which is the other principle of it, can teach people to it's new learning that inhibits the old learning. So basically, the old learning is our OCD learning, and the new learning teaches us that we can tolerate the distress, that we don't have to do anything compulsive with the feelings. We can like just sit with it and build tolerance for it.
Ooh, okay. I mean, you're packaging it in such a neat way. I kind of love it. I see the appeal of it as a therapist. Just offhand, like how long have you been doing ERP?
Oh, see,
I know, right?
know.
We never know the time. Time just goes by.
It really does. Because I learned about OCD early on in my career, and I've been in the career 20 years.
Okay.
But probably at like year 4, I learned about OCD. That was my first case that I consciously like, oh no, this is what it is, and I missed it. And then it took me several years to get the training. So I don't even know at this point.
At least a decade. At least.
I would think, yes. I would think, yes. Fair.
Oh, wow. Okay. So safe to say you're committed to it. You see the benefits in real time with clients. And so it feeds itself. Like I can keep doing this because there are actual observable progress happening in front of you.
Yes, it's crazy. It works so well.
Because so much of therapy is planting the seed and maybe you don't get to see it bloom. But with ERP, that is a really rare thing within the therapeutic setting of like, no, we're going to see like actual progress in real time. So that's the appeal of it.
That is why I love it.
Well, and then we're kind of hitting it on the head. You know, how does ERP differ from traditional talk therapy?
So it's very systematic, which I love a protocol. Give me a system to follow. I will do it. Tell me the steps, So it's a very systematic process of like identifying all their obsessions, their compulsive behavior, and then we treat it in a certain hierarchical sort of way. I know we were going to talk about the hierarchy, but we do it in this gradual exposure way until the person starts learning in all areas where the obsessions could come up that they don't have to do the compulsive behavior. So I
So
think it generalizes at some point.
So for therapists who really enjoy, we say this is behaviorism. Like if you enjoy behaviorism, if you enjoy a protocol, if you enjoy data, because I've seen sort of the assessments and the tools used, this is a modality for you for sure.
It definitely takes a certain personality type. I thought everyone would love
Mhm,
ERP, and then I trained a bunch of people who were like, "Yeah, not my thing."
mhm, mhm.
Systematic. Yeah, I love a protocol. And then I just break from the protocol, but for other reasons, right? But once you learn it, it's like dancing. You make up your own
Yes.
moves, you just kind of understand how it works. It's less
Well,
cumbersome.
and then I kind of feel naive saying this, but I would hope that those clinicians who are doing ERP are doing it because they actually enjoy it and are good at it, right? Like it kind of weeds out the fair weathered people because I was one of them. Like I gave it a shot and I was like, oh, I don't like this. I'm super relational. I don't like being so like systemic in that way. And so I want to believe that everybody who's doing ERP is doing it because that just is how their brain works as a clinician and they do it well, hopefully. Yeah.
Yes. There's so many protocols out there. That's the ideal.
Right,
Yes.
right. Well, and we talked about it a little bit. What is a hierarchy in the context of ERP therapy?
So this is where I actually write it out. Their obsessions and compulsions, and in the more traditional forms of ERP, they want you to do 1 through 100. So you rate it one
Okay.
through 100 each, and they can have the same number. So each obsession and compulsion. But for me, I do 1 through 10. 1 through 100 is such a big number. It's
Yeah.
confusing. I'm like, oh, that's too many numbers to decide upon. 1 through 10 gives me a basic understanding of what we're going to do. And then you start with the lower ones that
Okay.
are distressing enough,
Hmm.
so that the person builds confidence, understands how ERP works, understands that it's about facing their fear. It's not about reassurance. It's not about all the things we do in therapy. You actually cannot do in this. We don't reassure our clients. We're not a part of their compulsive loop. Um, yeah, I love it. Yeah.
So, all the more reason that if anybody is going to serve the OCD population, they really need to know their stuff. They need to know how to not become a part of the compulsion loop because it's such a slippery slope. We're such like certified nice people and we're like, no, you're fine, you're okay, which it has its place in therapy, but not when treating OCD because then you become a part of it and that's
Correct.
not helpful, not a good thing for us to be doing, and it is a band-aid on a gaping wound. Basically ERP is the sutures that are going to heal and like empower and rebuild the muscle, all that, going with that metaphor. So I always use that as a litmus test for, is this OCD that I am seeing? If, I naturally go to wanting to validate feelings and reassuring, and it is not necessarily helping the presenting concern and maybe sometimes even making it worse, that is a clue for me. Oh, I need to assess to see if this is OCD in front of me. They may not have arrived to session with that. They may be conceptualizing it as purely anxiety, but it's kind of a tip off of like, oh, I need to be more I don't know, intentional about assessing that, I suppose. Um,
Definitely.
does that make sense? Does that track? Like just,
Yes, because I think what happens when it's OCD, they feel better and they want to see us. They would see
Mhm.
us 20 times a week, right?
Right.
They feel better when we reassure them and say, yeah, oh no, you're not a killer, or yeah, your relationship's good, or whatever it is, right? You're not the opposite sexual orientation, whatever the fear is that they're having. Our reassurance does make them feel better. So then we feel like, I'm a great therapist. But if it doesn't resolve it, like somebody that doesn't have OCD, they get some facts, they're like, oh, okay, yeah, that makes sense. People with OCD, they just keep going back in it. And that really is an indicator that there's something else going on. Yeah.
Absolutely. And then you refer to people like you who actually, know a thing or two about ERP. But I'm so curious, what is the role of a therapist when implementing ERP?
So it's a really interesting question. I guess I've never thought about it. My role, but this is my role always. So my role as a therapist in general is I'm holding my clients accountable for whatever we're working on. And this
Okay.
is not in a mean way. For some reason, therapists think accountability equals bad rapport. I don't
Mhm.
know why, but like for some reason, if you're holding people accountable, you're going to be mean. I'm very sweet. I'm very warm about it. I'm like, why didn't you do your homework? I know we talked about this, but you didn't do it. Why is that? It can seem abrupt, even for me inside. I know I'm being really warm and kind about it, but it can feel like, oh, I might have upset them. And so I often, my role's just different. I explain how I work. Like I'm about accountability. I'm about like the homework and figuring out why you couldn't do it. Was the ask too big? Do we need to lessen it? My role, it's just different. It's not just about warmth and understanding, even though I'm very understanding because people with OCD sometimes obsess about if they're a killer. And so I'm very warm about that stuff. Those are scary things to imagine about oneself, especially when they're not. It's so terrifying. And so, and that they're going to lose control maybe and kill someone. So I want to be warm and understanding, but I also want to, I call it like a funnel. I want to channel them
Yeah.
towards change.
So I'm hearing like an ideal clinician in this role would be non-judgmental because there's a lot of shame that comes with the obsessive thoughts and sometimes the compulsive behaviors. But they also need to have a certain level of confidence and comfort in therapeutic confrontation because it's not on the street confrontation. I'm pointing my finger at you, but it is a why didn't that happen in between session? And they also have to have a good memory because I know some therapists operate like we're going to make the most of our time together in the 60 minutes that we have. And like we may pick back up again, or we may start fresh with our next session. With ERP, it is, we got to make sure we are documenting and documenting it in a way that is therapeutically valuable that helps us remember what we're doing in session, but we have to know what we did last session. Like we have to follow up. We have to be accountable to ourselves and to the practice and to the session. So a really good clinician would have to kind of possess all those characteristics, it sounds like. Would you say that's like a safe assumption?
Yes, I
Okay.
will say I have a crazy memory, thankfully. I cannot remember names of things to save my life, like names of nouns and people's names and stuff like that, but I remember their exposures.
Do
So
you? Do
I
you?
don't have to often write it down. Yeah, it's crazy. I'll write it down when they're in here, but once I write it, like, and I shred
Mhm.
the paper, I remember it. It's
Yeah.
so, but as a general rule, yes, you need to remember, you need to go back and follow up.
Mhm.
I do coaching sessions. I do a lot of things in between to help. And I also use this with people with like panic disorder or generalized anxiety disorder, phobias, any
Okay.
sort of, I call it a safety behavior, but it's basically a
Okay.
compulsion.
So it's a
Um,
transferable skill. Like it doesn't have to be relegated to OCD. Some of the skills within ERP are applicable to other diagnoses.
yes.
Okay. Wow. I didn't realize that. That's really helpful to know. So even if somebody is like not wanting to practice hardcore capital E, capital R, capital P, there is still some value in learning about it because the skills are transferable.
Yes, yes. And I think, when you get this idea that repetitive exposure teaches people about their anxiety or
Mhm.
teaches them that they can do it, like it's such a powerful tool to reinforce with your clients.
Mhm.
And it creates like a self-confidence, this ability to believe in themselves that they can
Yes.
do hard things. I mean, oh, there's so many good things about it. And for people, who've had like a trauma, maybe they're not driving again because of like a traumatic car accident. I'm trying to think of ideas related to that. When they realize they can drive, even though they're scary, it starts to break its hold on them. I just think it's really good work.
Well, being able to witness that and be in it with them in that way sounds like it is a very like self-fulfilling, a rewarding sort of process for the therapist. Um,
Yes.
to just to see that light bulb moment, to see that moment where it's a paradigm shift for them and they've gone from living in fear to living in possibility, to living in hope. So God, you're really selling it to me right now. But I mean, I want to know, are there certain clients that are not appropriate for ERP
This
that
is
you
interesting. So when I got trained, like they would do ERP on trauma.
Mhm.
A lot of people with OCD have a trauma history as well. So technically, you could take someone from a car accident who's traumatized and do exposure work, and technically they would get through it. I just think with that population, if it was that closely related, I would be doing trauma work along with exposure. I mean, yeah,
Okay.
with exposure work. Um,
Mhm.
because actual trauma processes are less cruel. There is a cruelty in ERP that when it comes to trauma, like somebody that was sexually abused, I wouldn't have them having sex with their partner if they were raped like a week ago or something like that.
Right, right. There are considerations to be had.
Yeah.
Mhm.
Yeah. Even though technically you could do it, it just seems wrong.
Mhm.
So, and then I love neurodivergence. You know this.
Yes.
Neurodiversity is one of my favorite topics. So I feel like people that are on the spectrum, even undiagnosed autism, like adult
Mhm.
diagnosed autistics who have just missed it, if they have OCD, ERP has to be done differently with that population.
Oh, tell me more. Tell me more. I'm so intrigued by this.
It needs to be slower.
Okay.
Sometimes
Pacing.
Yeah, sometimes they just live by the rules of their compulsions. And
Mhm.
so it's really hard to break free and get them to be willing to stop. Like they're like, I just wear a glove to open the door. What's the big deal? Right?
True.
Like they're just they're sometimes they're a little more habit driven. And so
Mhm.
those habits just are easy for them to abide by. Um, so I think that's important. I also think there are some ADHDers. I've been
Mhm.
stuck on this. You know more about this than I do, but you mentioned once like sluggish processing.
Mhm.
And I started observing it in my clients. And I find that
Really?
people that have a sluggish processing who are like just a little, like we might say something in here, but it's like once they leave, they think about what we talked about. And
Mhm.
then they're like, I don't know if I can do that exposure work. That was too much. Um,
Mhm.
and then
Mhm.
they'll text me, so hey, I don't know if I can do it. I'm starting to note those individuals and to tell them, hey, you might leave here and think this is impossible.
Mhm.
Some people need time to process what we said. And
Okay.
I find those people need to go slower.
That makes sense. So you're just adapting to what the client needs, basically. And it's not a resistance I'm hearing, it's a processing thing. Like they just need that time. And so it would be incorrect to be like, well, this is a treatment interfering behavior because it's not. They're literally just having they need that time to make it make sense.
Yes.
Okay.
Because
Okay.
the sluggish processing people, I find they're very agreeable. So they'll be like,
Mhm.
"Ah, sure, yeah, I'm doing it, you know? And then
Yeah.
they leave and it's like, oh, that was too much. And then they have the onslaught of terror.
Yes.
Yeah.
Yes. Wow. So it's like the gold standard, but even with the gold standard, there are considerations client to client and neurotype to neurotype. So it's it's a good foundation, but it can't be the end all be all. There has to be considerations around the person. Huh.
Yes.
Okay.
And how small do we need to start for it to
Mm-hmm.
be attainable for the person?
Yes.
It really is about engagement. And if I have to say the exposure is, I'm going to wash my hands 10 times, and the normal number is 12, because 12 is a magical number. So for this individual, right? So we are just going to 10 because 10 is all they can bear.
Mhm.
And that's not for me to say they're failing. They did it 10 times. It's not ideal in terms of ERP, but if it gets them to start believing they can do it, then we're going to get to where we need to be. It's just going to be at a slower pace.
Well, and that's one thing where perhaps I'm doing traditional talk therapy with a client and then they're also doing ERP. I'm always in awe of the level of creativity that is necessary for ERP, in my opinion, because I never know how to conceptualize, well, what is an exposure? And for you, because you've been doing it for so long, I'll say, okay, well, this is the obsession, and this is a compulsion. And you'll be like, it's this, you just got to do this thing. And I'm always like, oh, yeah, that's right. That's what you could do for exposure. So I do think, I mean, and you can disagree, but to me, it seems like it takes a level of creativity.
Yes. I think that's why I like it.
Yeah.
And no single individual, like normally the compulsions are a mix of stuff.
Mhm.
So every human is different that enters my office. And so I love that creativity and creating the exposures with them, and teaching them about themselves. People that have OCD are neurologically different than other individuals. They don't think it's a cause, but it is a difference. And so they are going to have OCD when they leave my office. So if
Mhm.
I can give them some like powerful tools on how to manage their mind, oh, yeah, it's meaningful.
it's meaningful, it's inspiring, it's tangible, which I think a lot of therapy can't say that about itself. So I see why you have been doing it for as long as you have, because it's always new. There's like the protocol, but then there's always new information, and it probably stays very novel, which makes a lot of sense.
I have ADHD. So yeah, novelness is important for me.
Mm-hmm. Well, that makes
Yeah.
complete sense. So for our ADHD clinicians, consider ERP. But no, honestly, this has been so helpful because um being adjacent to you in the practice, I love to know what everybody else is doing in session, right? Not everybody, it's therapy is universal, but then how we are doing it is so different. And it
Mhm.
also helps me confidently refer to you. When I do suspect it's OCD, when I do kind of confirm that's probably what it is, I'm like, well, I know a person who can absolutely help you. And so it's nice to have that in my back pocket. Is there anything about ERP that we didn't get to talk about that gets you really excited about ERP?
I guess we didn't talk about the behavioral piece in terms of like motivating clients,
Ooh, okay, yes.
which I think that's what ERP has given me as a clinician, no matter who I'm working with. It's allowed me to like figure out how to motivate people,
Mhm.
um, how to point out what's not working, whether it's I'm drinking too much, I have a compulsive loop I'm doing, oh, maybe I'm in a relationship with a horrible partner. Like I'm not, but like
Right.
those would be examples. My guy's really good. But
Mhm.
those are all examples of like where we could get stuck with our client. And when you
Yes.
understand how to motivate people and how to bring this up, these are uncomfortable conversations to have with your clients, to be
Mhm.
like, hey, you are coming to me to have a better life, but you keep going back to this guy that's abusive to you.
Yeah.
Maybe that's part of the problem. I think before I was trained in ERP, I was afraid to say the obvious if the
Mhm.
client didn't already say it. Like I was afraid I was going to make them uncomfortable. And
Mhm.
now I'm not. Now I'm just like, let's just say the obvious. Like this is the elephant in the room.
And for what it's worth, I've always gotten that feedback of like, you can tell me how it is. You can tell me how I am. So it sounds like ERP gave you the language and the conceptualization to provide that to clients.
Yes.
One thing that it made me think of just now, you have a very low turnover. You weren't cranking out clients. Like usually, because I think maybe a newer clinician would be like, well, that's really scary. What if I scare them away? What if I make them angry? What if they don't like it? That is not your experience.
No. No, I think this population in general, most people that have phobias or panic attacks or OCD, they are so distraught.
Mhm.
They live in so much torment. And most people don't push them. They're like, oh, they're in their loop right now. Let me just leave them be. I don't want to upset them. The fact that I would say, like, maybe you shouldn't wash your hands that much, they're thinking it. And I think to have it spelled out because they're in the loop all the time. So for me to spell it out, like this is making your anxiety worse every time you keep doing this compulsion, just that honesty really it creates safety. Me and you talk about this. I've been thinking about rapport and how good attuned rapport is about this push and pull, that the tug of war is what creates attachment.
Mhm.
Um, just us sitting and doing, that's hard, people don't feel attached, you have to be expressive in it, like, oh, that is really hard. Or I'm thinking of some of the old school therapists who would just agree,
Right.
like,
Yeah.
it's what we were supposed to do. Now we're going to be more expressive, and we might even say like that sounds really bad, or I don't know, we're just going to be more real. And I love ERP for that reason. Yeah.
Absolutely. Well, I'm thinking like if somebody comes to you and says like, I think I'm a pedophile because they have like pedophile OCD, for you to just be like, oh, that sounds really tough. Hello, read the room. Like they want to like, yes, that sounds awful. I'm so
Yes.
sorry your brain is plaguing you that way. Let's figure out a way to like really, I don't know, like just get you not so preoccupied with it and to feel like you don't have to engage in compulsions anymore. Yeah, so it does call for that level of attunement and attachment, which is really, I think, our bread and butter over here. We love doing that kind of stuff. So
Definitely. Yeah.
I love this. ERP sounds fascinating. If people want to learn more about ERP, if therapists want to learn more about ERP, where can they go?
So I have an intro course that already happened this year. I have a just for anxiety disorders and OCD, and then I'm
Mhm.
doing a second one on just ERP.
Ooh,
So that's coming up. Yeah, I'm excited about that. I also think you should consult. It is so counterintuitive to how we normally work that taking the training probably isn't enough. It's going to feel
just
so wrong.
synthesize it and like apply it. And okay, so consultation you recommend.
Yes. Yes, yes, yes.
Okay.
Afterwards, and I have other courses I'm offering. You can take other courses with other places. The iocdf.org is where I got trained. They have really good courses. My main thing with anyone that wants to learn about this, stick with one part of it. So if you want to learn about ERP, only take ERP trainings for a while.
Okay.
Uh, if you want to learn about ACT with OCD, only take ACT with OCD for a while.
Okay.
ERP is just so specific. In order to do it well and effectively, you have to understand it on a very deep level.
So
Um,
treating OCD is a marathon, not a sprint. It's expected that it will take time, practice, consultation before you can be a real like expert, so to speak.
and efficient in it, yeah, because it feels mean. The way we're trained, it feels wrong to hold someone accountable to facing their worst fear repetitively. I mean, that's what we're asking.
Mhm.
Yeah,
This is really helpful. Thank you so much.
you're welcome. All right, bye.